forum, Dr. Aseem Dhall. Silence anybody. So it's a delight that Dr. Aseem will be with us and he will tell you about my chair.
Well, good evening everybody. I welcome you all on the behalf of Indian Spinal Injury Center. So, I am cardiologist, the chief cardiologist working in the Indian Spinal Injury Center. I did my MBBS and MD medicine from Cmes and then I did my DM in cardiology from one of the most prestigious institutes, King George Medical College, Lucknow. And after that, in 2000, I joined Sir Gangaram Hospital for 6 months as junior consultant. And then in 2001, I joined Scott's Heart Institute and had a long career in Scott's Heart Institute for 18 years, for 16, 17 years. And then in 2016, I got the opportunity to work in Indian Spinal Injury Center as a part of Saurabh Cardiology, who had opened the cardiac center and Indian Spinal Injury Center. And for the last 2 years, the center was taken up by Indian Spinal Injury Center itself. And since then, we have been delivering the services of cardiology, both non-invasive as well as invasive cardiology services. So I think I thank Dr. Sushil Chauhan for a very exhaustive and very personalized introduction of all of us. And it's been a pleasure. I've had 3 CMEs before. This is 4th CME with your forum. And I'll be delivering a short case presentation followed by Dr. Saurabh's presentation and then by Dr. Raj Kumar's. Thank you.
I just request all of you to please keep decorum during the CME. I need another CME from Indian Spinal down the line 3 months. And the first CME in September is going to be Dr. Ashok Chakraborty on vaccines. Thank you, sir. Thank you so much. Over to you, sir.
Thank you, sir. So I hope I am loud and clear to everyone.
Yes, sir.
Thank you. So this was a complex primary angioplasty case in a dense calcified lesion, and we had used the technology of intravascular lithotripsy in this case. So our patient was a 67 years old gentleman. He was non-smoker, non-diabetic.
लाइट ऑफ कर दो बेटा लाइट
Can you put off the light, please?
इधर से
So, 67 years old gentleman, non-smoker, non-diabetic. He came with severe retrosternal chest pain associated with sweating in the emergency. And we had done a past RCA stenting in 2023 in his case. So when he arrived, he was profusely sweating. He was having a very low blood pressure. Blood pressure was 60 or 70 systolic, and oxygen saturation was quite less. And on inotropes, we maintained the blood pressure to 90 millimeter systolic. We did ECG, which was suggestive of acute posterior wall myocardial infarction. The cardiac markers were raised, and on echo, he had a moderate mitral regurgitation with a regional wall motion abnormality and a severe LV dysfunction. So this was a complex case, acute myocardial infarction. Patient was in cardiogenic shock, profusely sweating, blood pressures almost negligible, and on top of that, he was having extreme bradycardia. And the blood pressure being maintained only on high inotropic support. So this was the angiography. We stabilized the patient on high inotropic support, and we did the angiography of this patient. So this was the right coronary artery which we had opened up. We had put in a stent in 2023, and this was quite patent. So the culprit lesion was this. As you can see, this is the artery which is flowing, and this has blocked a total occlusion of, this is left circumflex artery. This is the left anterior descending artery, which is fairly okay, with a small mild lesion in the proximal part. So we proceeded with angioplasty in this case, and after passing the wire, we could find some flow in the artery, and then we did the balloon dilatation of this with a 2 millimeter balloon. So if you can see that this balloon is not opening well, and this shows that once the balloon does not open well, the lesion preparation is not adequate, and subsequently the stent cannot be deployed in such cases. So before deploying a stent, it is extremely important that the lesion has to be adequately prepared. So if you can see that there is some notch, the balloon has not opened up fully. And in this you can see, once whatever balloon did the job, the artery started flowing. Post flowing of the artery, patient's hemodynamics slightly became better, sweating decreased, although he was on high inotropic support. And you can see a huge chunk of calcium which was sitting at this point where the artery was totally occluded. So normally this artery flows straight. So if you can see that there is a bump like this, and this bump is because the calcium is pressing the artery. So we stabilized this patient because he was not in a condition that we could do primary angioplasty further. We were not able to open the lesion well because of the huge calcium burden, and because we were not able to open the artery well. So we thought of another procedure which was in the form of a debulking strategy in the form of calcium ablation by intravascular lithotripsy. So we had planned this. Since intravascular lithotripsy is generally not present in the hospitals because it is a costly device, so it has to be planned. So once the artery was flowing, the chest pain decreased, the hemodynamics improved, and so we could take a chance on that patient that we could stabilize this patient further for another 24 hours, and then subsequently after a day we took this patient for angioplasty. So now this is the balloon, which is a pre-dilatation balloon, a 2 into 12 millimeter balloon which opened the artery. And then this was the intravascular lithotripsy which was done. So what is intravascular lithotripsy? It is just a balloon in which there are emitters which emits ultrasonic waves, and by ultrasonic waves they break the calcium. A normal balloon does not open the hard calcium. So there are modalities of opening up calcified arteries, and this is one of the latest techniques which we are using. A simple technique, but a costly one definitely. But with this you can see, once we used, so we gave 10 pulses of this intravascular lithotripsy. One pulse means the balloon emits the ultrasonic radiations, and these ultrasonic waves, they pass across the blood vessel wall and they crack the calcium. And once the calcium is cracked, then subsequently when we dilate the balloon dilates well. So this is what is happening. So in this you can see that the balloon has slightly opened up better, and the artery, if you can appreciate, earlier the artery contour was like this. Now it has started opening after the intravascular lithotripsy. The artery has a little bit straightened and the balloon has started opening well. So this was the post intravascular lithotripsy, and again a balloon which was used to open the artery well. So after this, once we were sure that we had fully dilated the artery and prepared the vascular bed, then we were ready for stent. So this was the stent which was deployed. This was 2.75 into 24 millimeter stent, and this was the deployment stage. So after that, the artery opened up well. This was now you can see the contour which was like this, or opening up like this. The artery is a little bit straightened because the calcium was broken, and and then subsequently this was a post-dilatation balloon which we did after opening up after deploying the stent, so as to fully oppose the stent to the vessel wall. And now this was the final result after dilating. The artery is flowing quite well. So now the important thing to understand from this case is, normally what we do in a primary angioplasty is we do a procedure in which you pass a wire, you do the balloon dilatation, and then you deploy the stent in one sitting. But in case if you are not able to do the vascular bed in a right position, it is worthless putting in a stent. So because in that case, if you put in a stent earlier, when you have not prepared the bed well, it is going to block, and the patient can again, in fact, he will definitely come within the hospital stay, he is going to have stent thrombosis. So the best way in such cases is to prepare the vascular bed by whatever means. You have so many modalities of dealing with calciums. Balloons are not able to deal with the calcium, so the IVL technique is the latest technique which we used, and so that is why the lesson which one learns from this case is that it is a good idea to achieve a TIMI-3 flow in acutely occluded artery, so that the hemodynamics get improved, the patient is relieved of his chest pain. And in cases where there is dense calcium, the stent is only to be deployed after full preparation of the vascular bed, which can be a staged procedure as we did in this case, using appropriate calcium debulking strategy, which was IVL in this case. Imaging techniques like OCT and IVUS would have aided us better in regarding the debulking strategy, and IVL helps in achieving effective treatment of heavily calcified lesions with acute luminal gain and low procedural complication rate, and optimizes the stent expansion and apposition. Thank you. Pardon, sir? So rotablation is one of the modalities for debulking strategies in calcified arteries.
Question answer later.
Acute myocardial infarction and such a sick patient who is sure to die on table, you cannot do rotablation, because rotablation will again cause more slow flow, because it pulverizes the calcium and shows showers of calcium across the vascular bed. So already occluded artery, once we open that artery, the showers go distally and again occlude the artery. So it is not worthwhile doing rotablation in primary angioplasty cases.
Thank you.
Sir, no question. Thank you to the end, sir, please.
Thank you, Dr. Aseem, for a very clear talk, and we'll have the questions in the end. There will be a lot of them, don't worry.
You can join us, sir. Over to our second mistake.
So thank you, Dr. Dhall. We'll have, as told by Dr. Chauhan, at the end of all the three sessions, we'll have questions. So next speaker is Dr. Saurabh Juneja. He is Director and Head of Cardiothoracic and Vascular Surgery in Indian Spinal Injury Center. After doing his MBBS, as told by Dr. Chauhan from UCMS, he did his MS from Pune and then MCH in Cardiothoracic Vascular Surgery from G.V. Pant Hospital. His area of interest are off-pump beat heart coronary bypass, total arterial revascularization, peripheral vascular surgery, and also minimally invasive keyhole cardiac surgery. So he will speak on advances in cardiac surgery. So I request Dr. Saurabh to start his talk.
Good evening, everyone. Greetings from Indian Spinal, and thanks for the very exhaustive introduction, and lovely. I have my first experience with this audience, and it was a very wonderful one. And thanks, Dr. Chauhan, deeply indebted. So today we speak on introduction to our specialty, which has started at Indian Spinal as a complete cardiac sciences unit. So I'll be just going through things which are recent advances and the things which we are doing. We as a new cardiac unit, we started this year, and so looking for your support. So what's new in cardiac therapy? So a lot of newer drugs for heart failure, and as Dr. Dhall mentioned, many PCI techniques to open up many lesions, so which leaves very few cases for us actually. So, but yes, we are now involving into more minimally invasive surgery. So for better, faster, shorter length of stay, and transcatheter techniques are coming up. So TAVR is there to stay. We offer also ECMO extracorporeal for some cardiogenic, resistant cardiogenic shock, and VA ECMO, and LVADs, and obviously gold standard heart transplant. So what we'll discuss today is something just to cover the topics of valve, coronary bypass, the MICS options which we can have, and surgery for some heart failure and aneurysm surgery. So what is new in management? So most of these procedures now require a shorter stay, and patient can be discharged quicker and can join their work quicker. Because earlier when we used to do a sternotomy, patient you had to take join back work at least after 6 to 8 weeks. So here with the option of just avoiding the sternotomy, and so few patients can be joined back work earlier. So surgical access, which was earlier 6 to 7 inches on the midline, now can be done by around 3-inch incisions. And so this is MICS, minimally invasive surgery, is less invasive, has a quicker recovery, and obviously has to be safe and meet the with good outcomes, and obviously good long-term results. They have to match the results of a standard, gold standard of a conventional surgery. So they help us. The infection rates are less, the blood transfusion rates are almost negligible, and early recovery and return to work, as I said, and obviously cosmetic benefit. So operations which can be possible through this is coronary artery bypass surgery with few selected patients, valve surgeries like aortic valve, mitral valve, and some congenital surgeries also like a atrial septal defect or a VSD. So what's new in valve replacement? So mitral valve surgery repair is a very good option for those patients which come to us early. So and the repair results are good because the native valve is the best valve. There is no prosthetic valve which can beat that. So if we can preserve the native valve, but that would require early referrals. And for aortic valves, repair results are not as good. We offer for younger patients less than 50 a mechanical valve, and tissue for more than 60, with a grey area between 50 to 60 as per the patient demand, because there is tissue valve degenerates in about 10 to 15 years and would require a reoperation. So valve used, as I said, mechanical tissue, and some stent mounted valves which help us do a MIS faster, because they require less valve sutures or even none. So this is a picture showing a schematic of the normal sternotomy which is done, and this is for a small left anterior thoracotomy for an AVR. This is for left anterolateral for a mitral valve surgery. So for these surgeries, we have to put the patient on bypass. Normally, what we meaning using the heart lung machine when we have to stop the heart and replace the valves. So we put the patients on cardiopulmonary bypass through the peripheral arteries like the femoral arteries, femoral veins, and the internal jugular going to the SVC. So here we take the patient on pump. So this is a modern looking cardiopulmonary bypass machine which is run by the perfusionist. The console, and these are the pumps, the oxygenator, here the blood is oxygenated and pumped back after oxygenation to the aorta. So this is done peripherally, which is normally a central cannulation. Was the conventional central cannulation is through the aorta, the RA and the IVC. So there are many options for aortic valve replacement now. There's conventional surgical valve, the sutureless valve for minimally invasive is an option, and transcatheter techniques, and some possibility if a transcatheter is not possible, a transapical can also be done, and obviously for degenerative valves and all, valve in valve option is also available in few. So this is another operative picture of a small end left endotheliectomy for an aortic valve replacement. So this is a valve being replaced by a tissue valve, and all the valve sutures are in place. This is an aorta which is being opened, and a tissue valve which is a trifleet is being seated. So these are the stent with the stent valves which don't require any suture now. They can just be they are crimped and then mounted on a expander and then loaded. So they help when the technique is minimally invasive and we don't have to struggle with the sutures. So this is an example of the picture. This is the head end, and a parasternal incision for a ASD or can be used for an MVR. This is another picture for a left anterior thoracotomy for an AVR. So this is another incision, a left anterior thoracotomy for MVR. So we don't require to cut the sternum. We can go through the ribs, and the healing is faster, and you can go joint back work faster. So these are pictures for a transcatheter valve replacement for aorta through femoral, and this is through an apical. So this is a picture of showing a TAVR being implanted. This is you can see the valve which is getting opened, and in this process is this is a valve which is being implanted, a balloon expandable valve. So for what's new in CABG, so CABG can be done in many ways. Conventional cardiopulmonary bypass, off-pump CABG, where we don't actually stop the heart, we just stabilize it and then perform the anastomosis. Total arterial bypass surgery is now advocated because chances of restenosis is less as compared to the conventional veins which are used earlier. MICS, as I told you, some robotic assisted surgeries and some hybrid surgeries. So old method used to require normally a lima and a vein graft on heart-lung machine, arrested heart, and there was some risk to having a stroke and kidney injury and all that because of cardiopulmonary bypass and CPB times. So, but newer methods, they will reduce the usage of blood and without heart-lung machine on beating heart, and and we do total arterial revascularization using the mammary, bilateral mammary, the radials. So this is a picture of the stabilization device which we use for off-pump beating heart surgery. So this is that device which is used on the LED, And so this is the Lima which has been anastomosed to the LAD. This is the anterior wall anastomosis. The rest of the heart continues to beat. So another picture of the stabilization for the inferior wall of the heart. The heart has been lifted up, and the stabilization is being used for this the right coronary artery. For the lateral, another stabilization devices are there. Like this is called the octopus. This is the starfish. So this is the apex of the heart, which is lifted towards the ceiling, and the anastomosis is being done on the lateral surface. And the heart continues to beat. We don't arrest. The anesthetist has to do a job. He has to stand with earlier he used to go a cup of tea while the CPB machine is running, but now the anesthetist is an integral part of the team and is very important for the success of the surgery. So these are the other devices which are available for minimally invasive beating heart surgery. So another device which helps us to harvest the mammary artery for the minimally invasive off-pump surgery. So this is the operative diagram which shows the starfish in place and a small opening in which the anastomosis is being performed. So this is a conventional heart surgery, so this is a mid-cap which can be done in few selected patients in which we can do the pump operation safely. So even the vein and the radial harvesting have undergone some advancements. So we can harvest the veins and the radial artery through smaller incisions through endoscopic methods. This is a conventional vein harvesting, the long saphenous vein being harvested. So these are the other endoscopic instruments available, and this is a picture of the endoscopic instrument, and this is the long saphenous vein, and this is being harvested through the endoscopic technique. So arterial grafts are preferred because Lima is a gold standard, but bilateral mammary is better for long-term patency, and Lima has a patency rate of more than 90% at 10 years, where vein about 50 to 60% they degenerate after 10 years, and a radial artery is somewhere in between. So we prefer more arterial grafts, bilateral mammaries, and good outcomes. So this is a picture of two mammary arteries which have been taken, the left antral mammary and the right antral mammary artery, to be anastomosis on the left and the right side. So sometimes the mammary artery doesn't reach the target, so we can do some composite grafts like a Lima Y to make more of total arterial, do all the grafts as much as possible. Then there is robotic surgery in few centers, and it is like a harvesting of the mammary and robot assisted surgeries, and some surgeries like can be performed fully robotic. So this is a robotic picture of a robot harvesting the mammary artery. So aortic aneurysm can be thoracic and abdominal aortic aneurysm can be repaired conventionally, and now with TIVAR the endovascular technique is possible. This is an example of a abdominal renal artery aortic aneurysm, infrarenal. This is another thoracic thoraco-abdominal aneurysm and a thoracic ascending arch aneurysm. So here we can do a hybrid technique of endovascular surgery plus a debranching technique to protect the arch vessels. So this is a completed post-op patient in which there was thoracic aortic aneurysm. So heart failure surgery has, heart failure is being now many newer advances and medical options are there. and we have these newer, some newer inotropes like leposimendane, IBP and LVAD, which can decompress the, and AF ablation can be done through cryo, and many newer techniques for heart failure from the cath lab. Mitra clip is also coming up, and it helps in very moribund patients with severe MR and severe comorbidities. ECMO is an option in which patient is in cardiology shock, not able to wean off inotropes, not being helped by IVP. So VA ECMO is a good option. LVAD is now like can be a destination therapy for few patients, and or a bridge to heart transplant. So this is the schematic of an impella which unloads the LV to the aorta, and these are costly devices costing more than around 25 lakh rupees. So, but they can be a life-saving option in some patients. VA ECMO for cardiogenic shock, and they are also, these are portable devices which can be used, and can be used when patients are being unable to wean off inotropes. And obviously the most established therapy for heart failure is cardiac transmission, where in North India we are lacking, but things are improving, and some centers are catching up. So cardiac surgery has evolved significantly, and more patients are high-risk patients, and they benefit from this minimally invasive options, and minimally invasive surgery, transcatheter, and hybrid and robotic surgery helps in reducing the morbidity and mortality despite the increase in the patient age and risk profile. Thank you.
So thank you, Dr. Saurabh, for covering almost all the aspects of cardiac surgery. I hope in next talk you will cover peripheral vascular surgery also, because time was limited and factor to that.
I forgot to mention, we also do peripheral vascular surgery like bypass, femoral, aortofemoral, and even varicose veins, laser ablation. So those are part of our armamentarium.
In next CME we will expect from you after 2-3 months.
Sure.
So next speaker, I think again I request Dr. Sunil Kapoor to introduce our next speaker.
It's a pleasure to introduce Dr. Raj Kumar, who is a pulmonary and a critical care specialist. He's been the head at Max for 7.5 years, okay, and he's got a fellowship from Australia in critical care, and he's got his own practice in Visantpur. So, fellow from my field, let's see what he does great.
Hello, good evening. I believe everybody is awake. Okay? Because you are going to enjoy this one, so let's walk through. So today I'm going to talk about hemoptysis because it's a common topic. People do have a lot of presentations, especially in the Indian settings, and I'm sure you all will have a lot of questions regarding this. So let's talk about some interesting cases on hemoptysis. So case 1. And everybody has to be involved, please. So this is a 67-year-old female who got a background of hypertension, diabetes, and dyslipidemia. Presents to emergency with a cough and expectoration for 2 months. And she was progressive, short of breath. On clinical examination, she had a little bit of a collapse, and what we find, her saturation is around 95% on room air. She had a normal ABG at this stage. And these are her basic labs, which includes normal counts. ESR is slightly elevated, procal was essentially normal, urine, blood, sputum, everything was normal. Then because she had a short of breath, the cardiac markers were done, they were essentially normal with the ejection fraction of 45%.
Sir, HP नहीं दिखा, hemoglobin.
G sir, 10.5.
Right.
Good. I just know it. Sorry. Okay. Yeah. So chest X-ray. So this is what we normally look for, chest X-ray. And she also had a CT scan, which I will show you later, so you can compare things. She had some patchy air space opacification and air bronchial in the right lung. She was started on some antibiotics, Tazac and Claribate, as a community-acquired infection, which we normally do, and was put on some supportive care. She was in ICU for 3 days. Then she slightly felt better, went to HDU for 2 days. Then she went to the ward for 9 days. And in this duration, the antibiotics were escalated because her counts were slightly going up. Now she develops a hemoptysis, so that's the crux. And she again had a CECT chest, which I will show you. And at this stage, she was referred to a pulmonologist that she has a hemoptysis, and please come and have a look. And I advise her a bronchoscopy. So these are the 2 CT scans. I will see if I can run them. They usually runs quite faster. Yeah, okay. I will slightly go back so you guys can see what's happening there. It doesn't move back. Okay. So run it again. Okay. So there is a airspace of specification and the consolidation, if you can see there on the top. Oops, I'm just moving forward. Okay, so now we are seeing the CT scan, which was initial on admission on 14 June, and there was some opacification in the right upper lobe. Now she again had a CT scan, and we will walk here. Okay, well, just go back again. So now she actually had some opacification in the lower lobe as well, which will go back. Yeah. Now you can see in the next CT scan, now something has come in the lower lobe as well. And there was something going in the upper lobe as well, if we can catch it. So essentially, whatever the disease was, it has progressed. So we did a bronchoscopy, and there are some bronchoscopy findings. So now I'm at the carina and entering in the right side. You can see some lot of white stuff there. All right. So this is the upper lobe right now where I'm going. Full of this cheesy material there, mainly at the lower end of the trachea. We try to clear it. Then we want to go down and see what's happening in the middle and the lower lobe. So middle and lower lobe doesn't look too bad. So obviously we come back and take a sample. We did some brushing and biopsy as well. So this was just to show you. So anybody who, I don't know if you want to have a guess what this is, this cheesy stuff which is in the lower trachea and the right upper lobe.
Aspergillosis.
Fungal infection.
Good. So I think there is a question time. We'll discuss all these things. Everything will come there. So let me just forward it. So that was for your interest, what we saw there.
Bronchial tuberculosis as well. Why not?
No answers right now, sir. I'm sure we'll get it. All right. So this is the result of the BAL, which obviously gives you an answer. The BAL shows there is a mycobacterium tuberculosis, and
That's what I told you.
no, sir. So will come. So obviously I know. So this was a case of endobronchial tuberculosis. So what happens in the endobronchial tuberculosis? There is an extension of parenchymal TB, which goes to your tracheobronchial tree. And it actually makes it narrow, and mainly the things which are involved is the upper lobe, mainly bronchi, and the trachea. There's a different classification. So the important thing is most of them, like actively caseating, edematous, fibrostenotic, all of them are bad because the patients suffer for a very, very long duration. And the granular ulcerative and non-specific do not have a very poor outcome. So the most important thing here to remember is the sequelae, what happens after endobronchial TB. So TB is very common in Indian settings, but you develop a bronchial stenosis and stricture, which can happen to significant amount of patients. So anybody, even if somebody presents with a parenchymal tuberculosis and have some issue which we'll talk, can develop a endobronchial TB. So it's very important awareness which is missing here. A lot of people can have atelectasis, post-obstructive bronchiectasis, and severe airway obstruction causing tracheal stenosis. And the gold standard, the way to diagnose, because there is no way you can diagnose endobronchial TB, the only way to diagnose is a bronchoscopy. You can do brushing and a biopsy as well, and then obviously send this for tuberculosis. The treatment remains isolation, anti-tubercular medications, and steroids. Steroids every few years go up and down, but very important in this scenario, because if you can prevent stenosis, you can actually give a good life to the patient. Once you develop the stenosis, then there will be a lot of trouble forever for that patient. So very, very important. And especially, you want to know if it's a sensitive tuberculosis or a resistant tuberculosis. If it is sensitive tuberculosis and you are using rifampicin, you need to increase the dose of steroid as well, like 1 milligram per kg. Otherwise, you can give 0.5 milligram per kg as well. There are a lot of complications, lot of procedures for the pulmonologist, but the patient do suffer. So the take-home message I want to give is, because we all deal with the pulmonary tuberculosis, early diagnosis and treatment is essential in preventing disabling complications of tracheobronchial stenosis, which can not only lead to morbidity, but even mortality, secondary to complications. And how do we diagnose it early? Only by bronchoscopy. There is no other way of you diagnosing endobronchial tuberculosis. Your patient, if you clinically examine the patient and you have a monophonic wheeze, that's a clue for you. Yes, I'm only one side, I'm listening to the sound. There is a stenosis. If there is a stenosis, you please refer to a pulmonologist for a bronchoscopy. All right, I believe that was my first case and hope you guys liked it. So let's move to the second one, which is a bit more complicated. All right, so what happens here? A 28-year-old male who was previously healthy now develops a cough, dyspnea, and a joint pain since 1 month. He has a hemoptysis since last 20 days and goes to a physician and who starts him on anti-tubercular medications. They do not improve and presents to a hospital. He go to another facility with this recurrent episode of hemoptysis and some progressive dyspnea. His routine investigations was sent. He was started on oxygen as we always do, put on some broad spectrum antibiotics, non-invasive ventilator and some supportive care. This is not his CT, but this is just for telling how things are. His hemoglobin on presentation was 7. His counts were elevated to 25,000 and his creatinine was 3 milligram per deciliter, 3. Urine routine micro show a lot of high red blood cells. So somebody was smart, sent his vasculitis screen as well, which is good. And his X-ray had, at that point of time, had bilateral infiltrates. His screen comes positive, vasculitis screen, and PR3 ANCA was positive. So he got a pulse dose of methylpred and cyclophosphamide. But what happens in that time, he continued to deteriorate and over the next 24 hours, he got intubated and ventilated. His ET showed increase in the blood secretions. His FiO2, which was initially around 50, has gone to 100% and he has more and more ET bleed. His speed to recruit his lungs was increased from 8 to start with, go to 10, gone to 12. And what happens if you give too much pressure? You have a barotrauma. He develops a subcutaneous emphysema. And the X-ray, which I will show you later, had some newborn mediastinum with ARDS, bilateral infiltrates on the lungs. His saturation drops to around 70 to 80%. His blood pressure drops, and now he requires a norepinephrine as well. He was sedated and paralyzed. Now the family brings to another hospital where I was working. So once somebody comes with a pneumonia mediation, the first thing we did is put 2 chest tubes in, just to make sure if we can optimize things. We optimized the ventilatory settings. We stopped the sedation, wanted to assess his neurology, and the labs were sent. He continued on to have some antibiotics and supportive care. So this is his presentation X-ray, obviously done after putting the chest tubes in. As you can see, 2 chest tubes there. And there's a lot of air around the heart, so he had a pneumonia mediastinum as well, and a lot of subcutaneous emphysema. You can see that what's happening in the muscles, a lot of air there. It did not have a significant improvement. So obviously we want to know what should we do. Should we just continue what we are doing, and wait for a recovery? Or should we do a prone ventilation because somebody who got an ARDS on high oxygen support, should we prone them? And the third and last option was ECMO. So who wants to continue the same? Obviously none. That's why the case is there. Okay, prone. So now there are guidelines. Anybody who has an ARDS should have a trial of prone ventilation before you even refer to somewhere else. So can we realistically prone him? He got so many chest tubes. It's very difficult. It's just almost impossible. So ECMO remains an option. So just for an overview of what ECMO is, I will just give an overview. I believe sir has already talked about cardiac ECMO. I will talk about the respiratory stuff. So the ECMO stands for extracorporeal membrane oxygenation. That means the oxygenation is done outside the body. It's a modified form of heart and lung machine. What it does, it is a form of extracorporeal support for a refractory. Refractory means which is not getting treated with basic what we normally do. Respiratory failure, refractory cardiac failure, or a refractory cardiorespiratory failure. These are the configurations of ECMO. VV, blood comes out of a vein, goes into a vein, we call VV. Supports your lung. Blood comes out of a vein, goes into an artery, we call VA. Supports your heart. This is the approach for VV because I would be talking about veno-vena ECMO. A two-side approach which we commonly do. The blood comes out of a vein and infra vena cava and goes back until we put through the jugular another cannula. Now we got a single cannula as well. So the patient can be mobilized if somebody has a single cannula or single site approach. So these are the indications which you need to know. When should you think of asking for ECMO or send a patient to a ECMO? So first indication is hypoxemic respiratory failure. So ECMO should be considered when the chance of dying is more than 50%. But how do I know my patient's chance of dying is 50% or not? So this is the simple thing here. PF ratio. We all look at the blood gas and we can look at a PO2 by FiO2 ratios. If it's less than 50% on more than 90% oxygen and or Murray score. So this is the Murray score I've given. There are 4 parameters which we look at: chest X-ray, hypoxemia, PEEP and compliance. As you can see, the numbers are given based on the severity and you divide it by 4. You get the Murray score. The chances of dying is more than 80%. If somebody has a PO2 FiO2 ratio is less than 80, on oxygen of more than 90%, or a Murray score of 3:4. But the ECMO you should only think of ECMO once you have given a trial of prone ventilation. So trial of prone position is important, and after optimizing the medical management. So it doesn't mean that you need to make sure first you do your ventilatory settings right. Another indications are carbon dioxide retention when the pH is less than 7.25, when you cannot ventilate them well. Despite increasing the respiratory rate very high, you are not able to achieve that pH by keeping your plateau pressure less than 30. Or if you have severe air leak syndromes, now the ELSO guidelines have added bridge to therapies, including transplant or sometimes even the decision making. Okay, so what next? Is he a candidate of ECMO? So obviously his chance of dying is very, very high. But before that we want to know, is the neurology fine? Because he got a multi-organ dysfunction syndrome, he is on inotropes, neurology we are not sure, very high ventilatory support, his kidney dysfunctions. Second, when we put patients on ECMO, we do use heparin. So somebody is already bleeding from your lungs. Do you really want to introduce more heparin? That's the question. Good. So now ELSO has come with this, what we call the RESP score, to decide whether the patient is a candidate for ECMO or not. Okay, it's for a respiratory ECMO survival prediction. It predicts if your patient goes on ECMO, will he survive or not? And the possibilities based on the score, you can see 1 to 5, 92% to 18%. But realistically, only 50% patients do survive on ECMO. So don't think that everybody who goes there is going to come out. But that number is also very good because with ventilator, the chance of dying is more than 80 to 90%. So 50 is a better number. And the second question which we had, can we really use the heparin? Somebody is already bleeding. And we tried to look at the data, pulmonary hemorrhage and ECMO, very limited data, but we did find some case reports. which suggests either don't use anticoagulation because the circuits are happening coated now. So that's one of the things. And some say use anticoagulation, patient will not bleed. So we looked at data that they actually put 4 patients on. Out of them 3 survived who had a pulmonary hemorrhage. We got encouraged with this study. So this is how you initiate ECMO. So there is obviously one intensivist, one cardiac surgeon, help for the cardiac surgeon here as well. There is a cardiac intensivist to look at the position for ECMO cannulas, and you need a perfusionist as well. So it's basically a teamwork. So if somebody says I'm going to do it, he's not going to do it. It's only the team which does it. Alright, so this happens after ECMO initiation, as you can see. Now we got big cannulas coming in, so let me see if I can. Yes, can you see this one here? This is a big cannula coming to the right atrium. There's another cannula here as well, which goes in, and the rest of the things, ventilator and everything remains similar. This vasculitis screen comes positive. Lab investigations, so the creatinine further rises, the counts further rises, there is a stress response. We had a lot of hematuria because we did use some heparin as well. We did a bronchoscopy which had some old clots, but there was no fresh bleeding going on, which is basically a savior for us. And now we come to a diagnosis of pulmonary hemorrhage secondary to GPA, granulomatosis polyangiitis, with a renal involvement. So the specific management is cyclophosphamide and pulse methyl, and we did a plasmapheresis as well. Broad spectrum antibiotics continue, rest lung settings, supportive care, and what you require is time. Once you put them on ECMO, you need to give them time for healing. Yes, sir, we'll come to that, unless you have it.
I was just thinking, but this patient probably has an autoimmune disease and anti-GBM disease. Would you say that?
We did send the anti-GBM as well, and that did not come positive.
Not positive?
No.
But this was an autoimmune disease.
Yes, it was autoimmune disease.
Wagner's.
Dr. Raj Kumar, I can first finish the case.
Let's do 3 more slides,
I
sir.
will give you time in the end, sir. Please.
I know it comes from inside.
Go ahead, sir, go ahead.
Anyway, I'm almost done, sir. So now 3 weeks on ECMO, the patient is liberated from the ECMO. 5 weeks he is discharged home. And this is the X-ray as you see here. So learning points here are pulmonary hemorrhage, even with the bleeding coming from the lungs, and we have to use heparin. ECMO is not contraindicated. Caution is must, obviously. What we did is we lower our anticoagulation targets. So the AC, we did reduce that, and this is the paper we published as well from my juniors, as you can see. And I think that's I'm done, sir. Now anybody can have questions.
So please come here.
Wonderful case.
Can you please come here? So I have requested for dinner for Dr. MPS Gandhi sir, Dr. Jasbir Singh sir, Dr. TN Rao sir, and any senior citizen who wants to have the
Light
just go to the next room, sir. Please come here. You want your dinner, sir? You want your dinner, sir. Dr. Aseem Dhall, Dr. Saurabh, please come here. So we will have. I think we had a wonderful presentation of cases, and so you have a lot of questions, relevant questions. So I would request each one of you to please note down your questions, and we'll come one by one. The first case was Dr. Aseem Dhall, and it's my privilege to give it to Dr. Sunil Kapoor sir to set the ball rolling, to set the context, and then we come to each one of you. Please.
Yeah, Dr. Dhall, it was a wonderful talk, and about all the AVL, and I think we'll go to the questions from the.
Yeah. All right, Dr. Sunil sir, I want to ask you: do you have a ACS program? Do you have an acute coronary syndrome program in your setup? If suppose somebody gets an ACS 2:30 AM, are you doing primary coronary angioplasty? Then who is doing it, sir? Are you doing it? Somebody else is doing it.
So I am doing it.
All right.
I have one more DM cardiology with me, but he also comes and I also come.
Right, sir. Sir, I wanted to ask you, in your setup, if someone goes into cardiogenic shock, I'm sure there must be some patients. What is the survival rate and what is your line of management?
See, the survival of cardiogenic shock is 50 to 80% mortality. And in the best of centers, this is US, I'm talking about not of India, I'm talking about US. So in our country, the mortality is to the tune of 80%.
Do you get cardiogenic shock in your
Yes,
setup?
yes. We had a patient who was a relative of Mr. Somnath Bharti, who was well managed, and he was, we did primary angioplasty in cardiogenic shock. And of course, mortality, I'm telling you, 80% mortality, but we could keep him for a couple of days and then shifted him for a LVAD or something higher to the Vedanta and other centers.
So those people who do not agree for primary coronary intervention, I'm sure you fall upon the option of thrombolizing them. What is your agent of choice for thrombolizing? Streptokinase, urokinase, or even tenecteplase?
Yeah, we always do with tenecteplase.
So that is an IV bolus, sir?
Yes, IV bolus.
30 milligram?
IV bolus, 40 milligram bolus, 40 milligram bolus and stat.
Right. So what is the success rate?
Success rate, I would say it is to the tune of 60%.
What do you do about the 40% who do not respond?
So we do the ECG, and the standard is that ECG is to be done at 60 minutes and 90 minutes. If the ST resolution is more than 50%, then that means it is a successful thrombolysis. And if the ST resolution is not less than, there's still elevated ST, then we consider, and if the patient is still having chest pain, sweating, or all those symptoms, then we go for a rescue angioplasty.
Right, sir. So suppose I am practicing in Sonipat, I want to send a case to you, and I have tenecteplase in my clinic, and I know that this is an extensive anterior wall ST elevation MI. Can I give tenecteplase in my clinic?
Absolutely.
And what is the risk?
So the risk has to be explained to the attendants. The risk is, this is his only chance in a primary, in a center where there is no facility for primary angioplasty. So of course you have to tell the patient's attendants the risk of bleeding per se, and that he has only this chance of going to a tertiary center. And as I said, 60% of the patients do respond well, the pain decreases, and then subsequently once the patient stabilizes, in such the centers, the tier 3 cities where there is no facility for primary angioplasty, you can subsequently shift your patients to the higher centers.
And do you have all the panels? Do you have CGHS, EC?
Yes, we have all the panels. This is very important for all of you to know. We have all the panels. In Vasant Kunj, Fortis Hospital is not catering to the panels. We are catering to all panels. You name a panel, we have it.
Great, sir. Great.
He raised a question of giving thrombolytic agents in the periphery. So can it be done at a clinic level or at nursing home? Because there is medical legal issue.
Of reperfusion arrhythmia.
So in a clinic setting, these things are not advisable because there are medical legal issues. Of course, patients can land up into. So in clinic settings, even if you give a simple iron injection, there are so many anaphylactic reactions, and even tenecteplase is not immune to such reactions. Any injection you should not be given in clinic. This is what I feel. So of course, this is once you have detected that this patient is having acute myocardial infarction, he is quite a critical patient which needs to be referred.
Sir, Dr. Rajani has a question.
About the particular case you discussed, you said the person was RCA was blocked and he was operated earlier in 2023. What was the status of left circumflex artery at that time?
So that was normal at that point of time.
Okay, because very soon he developed so much calcification that we had to do IVL.
Yes. So the artery was totally normal at that point of time. And when the artery was open, it is hard to see calcium. The calcium was not even seen once the balloon was dilated. We could only assess the calcium because the balloon could not open well. And that is why, otherwise the calcium was not visible on the angiography. Because
there because
of course it was there, it was a huge calcium burden, and that is the reason the balloon did not open. So the angiography is not a good modality for assessing the calcium. The IVUS and OCTs are better modalities for assessing those calcium burdens.
So we don't you usually get relaxed if you are operated in 2023. You don't think after 6 months or a year you are going to go for an angioplasty again.
Yeah, but so many patients, this is called malignant coronary artery disease, which we all Indians have. So you can't help it.
Thank you.
I think we need to be more aggressive with our statins in these people. So that is the message. Dr. Shireen ma'am, if you could just give me, how are you ma'am? God bless you. Dr. Ashok Chakraborty, you raised your hand. Sir is so wonderful. He says, my wife has asked the question. I have answered. I'm coming. Dr. Manu Saxena sir.
Sir, what are the conditions when you use rota ablation? Because you said that in that patient you could not use rota ablation. So when did you use it?
So rotablation is used in stable patients who are not ACS patients, not acute coronary syndrome and not acute MI patients. They are used in densely calcified lesions and with stable patients in which we are doing routine angiographies and we find that there is a huge calcium burden.
But you can't see the calcium.
You can see calcium, but this was a unique case in which you did not expect that calcium burden.
But you just said to her answer that angiography is not a good way to see calcium.
No.
So how can you see the calcium routine?
Angiography is a good tool where this is the only tool where we can see calcium. But in some cases you are not able to see calcium. In those cases, there are better modalities to see calcium.
Right. Dr. M.P.S. Gandhi sir.
Is there any role of calcium scoring in such cases?
Yes, there are calcium scoring systems based on IVUS scoring systems and OCT scoring systems, and depending upon these imaging techniques, we decide what modality of debulking strategy is to be used.
Dr. Tulsi sir. Yeah, you are. We are early to you for Dr. Aseem Dhall and then to Dr. M.L. Kalda sir, and then we'll go to Dr. Saurabh Juneja. Please. 2 minutes to you, sir. For Dr. Aseem Dhall.
5 minutes, sir. So, not that. Great talk. Heavily calcified right coronary artery. Why did you choose OCT? Sorry, I was in place of OCT. This patient was not a renally compromised patient. OCT would probably give you more resolutions as compared to the IVUS. Talk us about this.
No, I said we did not use any imaging technique. We did not use OCT, we did not use IVUS. We only tried opening the artery with balloon which could not open well, and that is why we opted for another therapy which is called lithotripsy, intravascular lithotripsy, IVL.
Okay.
Right.
So, Dr. Dhall, can you tell us, did you heavy calcified lesions, did you check for lipoprotein little a here?
So acute MI situations, we don't check because we don't have time. We immediately take these patients for primary angioplasty, and these patients are subsequently evaluated for higher risk factors.
Because heavily calcified lesions, probably lipoprotein probably would be high.
Yes.
So these patients would probably be needing, PCSK9 inhibitors, and also the newer drug today, leposidiran, is the newer modality of choice here to take care of the high lipoprotein. Having said that, why I said, can you tell us the difference between OCT versus IVUS in such like patients if we have to image?
So OCT, we normally do IVUS imaging. Yes, we normally, because it gives us, the modality gives us arc of calcium, the angle of calcium, the width of calcium, the thickness of calcium. OCT is a good modality, but in say left main situations, it is not a good modality. But generally, then again, in such situations, we have to give very little dye because these patients we have not tested for renal functions, and OCT we have to give dye during that. So IVUS is a better option.
So OCT is superior to IVUS in characterizing the plaque
Yes.
morphology. So maybe a better choice. Anyway, sir, fine, thank you. To Dr. Juneja, can we ask? No? Okay.
Sir, pardon me for my ignorance if I am very naive. When we are giving arterial grafts for your CABG, so do we make any changes to the arteries we graft? Can we make them drug-eluting, or it is only the arteries given as such in the novo position? Can we make them drug-eluting? Can we treat them before giving the graft?
No. Arterial grafts are themselves resistant to thrombosis. So arteries, especially the mammary artery, have a characteristic of not forming stenosis. So very few chances, as I showed, 90% remain patent at 10 years. And so that is the gold standard for arterial grafts. But
to improve their functioning.
no, sir. That has to be done medically, sir. Though with the medical this thing, we can't treat them in situ.
Very good question, Dr. Kalra sir. I just want to inform you कि सर आज जो स्वीडिश है ना, मैंने बहुत ही स्पेशल डिमांड पे बनवाई है। घेवर सर, मैंने घेवर बनवाया है सर, और सर वो उसको सोर्स करना।
Talking about the sweet trial.
Sir, I am talking about sweet dish. वो जो घेवर है सर, वो बहुत ही एफर्ट के बाद बनवाया, क्योंकि इनके पास जो खांचे थे ना, वो खांचे बहुत लिमिटेड थे, 16 थे, और हमें सर चाहिए था वो 64। तो इन्होंने सर उनको 64 किया, और हमारे पास एनफ घेवर है, लेकिन दिक्कत ये है कि बहुत लोग खा रहे हैं, तो यू बी क्विक अबाउट इट। नो, आई एम जस्ट इन्फॉर्मिंग यू, दैट्स ऑल। मुझे और कोई प्रॉब्लम नहीं है।
ग्राफ्ट के लिए खतरा है सर।
हाँ, ग्राफ्ट के लिए खतरा है। डॉक्टर, सो वी आर डन विद क्वेश्चनिंग विद डॉक्टर असीम। आई विल कम टू डॉक्टर सौरभ। डॉक्टर सौरभ, वंडरफुल प्रेजेंटेशन। I just wanted to ask you a few questions. In your setup, a routine bypass, how much does it cost?
Sir, our CABG package is around 2.5 lakhs.
And if you use an IABP, then
IABP costs about 1 lakh more.
So it will be now 3.5 lakhs.
Yes, sir. If IBP is used, IBP is used for those patients who have severely compromised
LV
dysfunctions or any other cause of moderate MR or something. So, but
what is the usual stay for a bypass patient in your setup?
Sir, we can discharge the patient as soon as the 5th post-op day, and our package is for 8 days, all inclusive. Even if we have to increase antibiotics or other modalities, also we are using even more ICU stay. So we have made a package all inclusive, which is about around 1.5 lakhs less than the other corporate hospitals. So that is our USP.
Dr. Manu sir, you want to ask a question to Dr. Saurabh sir? All right, sir, I'll ask you a question. You mentioned about the valves, and you mentioned about some of the devices that we are using. I wanted to ask you, are you using MitraClip, which is a very costly device? Are you using it? The MitraClip?
No, sir. This is actually done in the cath lab with the cardiologist. So, but if we have a patient of severe MR with a lot of morbidity and very high risk, STS score very high, who will not be able to survive, very high risk of anesthesia. So, MitraClip is an option which will tide him through. Suppose a 85-year-old gentleman or a lady, and with renal dysfunction, and which carries a very high risk. So those can be.
Right. Dr. Sen Gupta sir, you have a question, sir? To Dr. Saurabh, Dr. Amish sir. Dr. Amish has a question. Dr. Amish has a question.
Sorry, little bit different question. In 2 years back, there was a small article of 2 pages in NEJM, and they had said on the weekend, the amount of procedures, including primary angioplasties and CABG, was much less compared to weekdays. This was a US data, not the Indian data. And they had found that the outcome was similar on Monday to Friday or Saturday, Sunday. Sorry if I have asked a wrong question, but this was an NEJM review of 2 pages article. Would like to know from both cardiologist and cardiothoracic surgeon about this weekend phenomena where the cardiologists are not available and you do a conservative treatment. Like, sir mentioned about ST depression of more than 30% or 50%. You feel that, your conservative management is better. Am I reading too much into the article, or is that a fact?
Dr. Dhall, would you like to answer that?
So, I also read that article. In that article, it was shown that Monday to Friday, the results were better. Saturday to Sunday, it was a holiday syndrome. In UK, US, they don't do angioplasties, primary angioplasties on Friday and Saturday and Sunday because they have their offs. But in India, we are laborers. You know it. Laborers work 7 days a week. I think that answers my question.
No, so on a serious note, what I wanted to ask was, when I was in a corporate hospital and when I started my own daycare center, what I realized that I myself was admitting 60 to 70% more than what it was required. And I don't have shame in admitting because the circumstances were different. Similarly, how many times, in the night, Max Hospital emergency, cardiologists after cardiologists were talking to each other, yeah, primary hai karega. And in the end, in the morning, you realize, Dr. Raj Kumar is laughing because he has seen that. In the morning, you realize sometimes patient is fine. My point is, sometimes I believe that probably I am overdoing things. Is that the same in cardiology field also? Something which you would give take-home message for people that 1, 2, 3, 4 do these steps and you can save your patient from procedures like angioplasty or CABG. It's a very, very simple, straightforward question. There is no pun intended here.
What I'll tell you is that acute MI is the only situation which has shown to improve the mortality and has mortality benefit. So, whether it is Monday or it is Saturday or Sunday, if a patient can go in a center where a primary angioplasty can be done, it is of course the best strategy. Now, it has to be decided by the cardiologist whether that patient warrants primary angioplasty or not. That's an altogether different question. But if the cardiology feels that this is acute, and sometimes what happens is that the patient is having chest pain for 3 to 4 days. Now he is at a primary center, say at Sonipat. So a physician there does not want to keep that patient on Saturday and Sunday and refers those patients to a higher center. Now this patient surely does not require a primary angioplasty because a cardiologist would know that there is no acute ST elevation, right? So he does not warrant primary angioplasty. These patients can be stabilized. And of course, it's a drain on the hospital resources to get a cardiologist or any doctor on weekends. And so that is the reason why these patients may be done on Monday, but if a ST elevation, acute ST elevation, acute chest pain comes to a hospital, in our hospital, we are bound to go and do it.
Excellent answering, Dr. Aseem. I want to ask both of you one question, which I have been struggling to understand for the last, I would say, few years. You mentioned about aortic valve replacement. And you also mentioned that the tissue walls have a problem of degenerating in the next 10 years. And they have a life of about 10 years. Now I want to ask you, if you have a patient who is only 35 years old, who has a bicuspid aortic valve, has severe aortic stenosis with a significant gradient and qualifies for aortic valve replacement. Sir, what do you do? Do you do AVR medically, I mean with the tissue valve, or you do a surgical AVR, which one has a longer longevity for the patient with less chances of degeneration, and which one will require less anticoagulation for life? So over to you, Dr. Saurabh first, and then I come to Dr. Aseem. So this has to be answered because most of us are having patients who have aortic stenosis, and we do not know that even if they spend out of pocket, which is the better option? Is it a surgical AVR or a prosthetic one, as we call it TAVI? So which is the best option for the patient? Just explain it to us in simple terms.
See, surgical AVR has both options of using a metallic valve as well as a tissue valve, whereas the TAVI only has a tissue valve options. So obviously tissue valve has its own complications in the sense that the longevity will be a complication, and I mean those factors of tissue valve degeneration will hold good. So as far as offering a patient, a 30-year-old patient for CVRS, definitely a surgical aortic valve replacement is a gold standard.
A surgical AVR with the tissue valve?
No, with the metallic valves.
With the metallic valve. With lifelong anticoagulation.
Lifelong anticoagulation, but if the patient is above near 60 years old, then I would definitely recommend him a tissue valve. If there is a low ROS and he has a good longevity, then surgical aortic valve replacement. But if he has, suppose, a 75-year-old gentleman with some comorbidity or even medium risk, or now the things are also for low risk, then a TAVR is a good option.
Right. So then I come to Dr. Aseem Dhall. Sir, what is the minimum cost of a TAVR in your setup? A reasonable kind of a valve. Now we know that the cost of the valves is coming down. It's not the days of 25, 28 lakhs for TAVR. I think we are now coming down to 10 to 12, 13 lakhs for TAVR. What is the cost in your setup, sir?
So we have not started the TAVR program.
You have not started TAVR.
The simple reason for that is that we did not have a surgical backup.
Right.
And a surgical backup is absolutely must.
Absolutely.
Because it has so many medical legal complications.
Right, sir.
So now we are going to start, and if you have patients of aortic stenosis, you can definitely refer. As far as your question goes, a young patient, surgical AVR is the choice.
Surgical AVR. I would come to any questions, sir? I would come to Dr. Tulsi for questions.
Dr. Juan, I must have many questions were raised which have ethical issues. I think, and you both, I think, answered very well, because these were ethical issues. What Dr. Anishwara asked and what Dr. Chauhan also asked, these were ethical issues, and you, I think, answered very well. In TAVI also, you said in young patient it should be surgery first, and not
that's a carry-on message for me. In a young patient, we should rather go for a surgical
AVR best with metallic valve, and 16 plus TAVI should be the first.
So there is a view, Dr. Poddar, but there is also always a counter view. So let's get to the counter view.
So to answer Dr. Chauhan's question to Dr. Dhall and to Juneja, also Dr. Poddar. So a 5-year recent study published in Circulation said TAVR as good as SAVR even in young low-risk patients. But the findings were similar. See, but this study was only of 5 years, mind you. So we have only a 5-year data where SAVR, TAVR equal benefits even in low risk younger patients. But we need a study which is beyond 5 years, and younger patients, probably as you said correctly, would benefit from a mechanical valve. We are not concerned much about bleeding than to do a redo procedure. What do you say, sir?
Yes, sir. As I said, these are basically tissue valves. These are same tissue valves which are being used for surgical aortic valve replacement for a longer time.
Absolutely.
But now they are crimped and loaded in a catheter and being deployed.
Right.
So the longevity is an issue. So these 5-year studies or long-term studies, so a low risk subset can be a 70-year-old low risk. where surgical aortic valve used to be a
No, sir. We are talking about low risk younger patients here.
Yes.
A 5-year study published recently in circulation.
See, many of these studies are industry driven.
No, sir. Circulation is a very good idea.
And now, see, US option of now valve in valve is there. So now that will be an option. But for our this thing, I am talking about a person requiring only one time lifetime surgery. Patient won't come to you second time. First.
As they said, bleeding is not a problem. It's the redo procedure which is a problem. So younger patients probably, as you correctly said, mechanical valves and have to be done. And saver here is a choice. Younger patients, there's no doubt. But I was just referring to the 5-year data published in circulation. We said equal results seen, saver, taver, younger patients, low risk patients. Thank you, sir.
I think redo surgery after TAVR is very difficult. If you want to use SAVR after TAVR, then that will be very difficult. I think Dr. Saurabh will agree. If you, in a young patient TAVR is done and after 15 years you have to do SAVR, that will be difficult, sir.
So that is a new scenario which is coming up, sir. To do surgical valve replacement after TAVR, that is a nightmare for the surgeons.
That's what
So now we are dealing with that, and there are being reports of surgical valve replacement requiring. So those are so much embedded in the LVOT. So to take out is a big nightmare and causing LVOT disruption. So that requires a Bendal. So we have to be rational. We should not jump the gun. There were, there are many studies being done, but for our setting, we should still now stick for our gold standard.
Sir, my question is not a really question, it's a comment on Dr. Vora's question. Malpractice means it can be omission or commission. So, as we said that maybe when you are, doctors are on leave and it's a conservative treatment, if someone gets complicated, so he may be sued for omission of the treatment. So, your comment on that?
See, you
overdoing or less doing? Both are.
You're talking about the weekend surgery?
Weekend and whatever. So there was interesting. I wanted to avoid this. There was an interesting point in some 1 century back that mortality of world over fell down when there was a world over doctor strike. So it doesn't mean that doctors are doing bad. So I'm just saying that if
we'll discuss it later.
yeah, no, I'm saying that if you are not doing something aggressively and it is required, you may be sued. And if you are overdoing, you can be sued.
Yes,
commission and commission.
Point taken, sir.
Just a minute. I think we had wonderful discussion for Dr. Aseem Dhall and Dr. Saurabh Juneja's talk. Give them a very big hand, please. Now coming to Dr. Raj Kumar's talk, I would request Dr. Sunil Kapoor sir to set the ball rolling for his talk, and then I go back to Dr. S K Poddar sir, and you can ask.
I just had a very small question for both the cardiologists and the CTVs regarding the scenario in India. With all your experience, do we have any trials which titrates SAVR versus TAVR, and regarding cost and the clinical scenario that we have? What would be a better way to go? Because people often get stuck. We also get stuck midway in trying to, basically tell the patients. Very practical.
As I told you, TAVR is an option for medium and high risk patients, and basically they want one-time surgery, especially in our scenario. So for younger patients, surgical aortic valve replacement remains the gold standard, and we should advise them that, because many patients they come for TAVR is nothing. It's because it's replacing a valve in valve. It doesn't look like because there also the heart is getting stopped. They fibrillate the heart for some time. There are complications of paravalvular leak which they accept. If a surgical aortic valve replacement has a paravalvular leak, it's a big hue and cry. But if the patient has, heart block, PPI rates are higher. So there are so many things, vascular complications, there are so many things. Centers which are doing like maybe 500 plus towers are very few. They have that experience. But centers are doing 1 or 2 of towers, I don't think so. They should get into this. The results vary.
A wonderful talk by Dr. Raj Kumar. And endobronchial tuberculosis is always a watershed. It's a very difficult thing and the simplest thing to fail a PG. Now, the other thing is you told us a lot about ECMO and a lot, things we learn new and a lot of things we learn new. Now, tell me, good endobronchial tuberculosis, we see an occasional gene expert or no?
So normally with the endobronchial TB, if we do a sputum examination, most of the time it comes negative.
Negative. Okay.
So the reason for that is the entrapment, because the lumen gets narrowed and you are not able to spread it out. So that's why the bronchoscopy becomes a gold standard. Now we go with the bronchoscopy and the differential remains significant as we were discussing. Is it a fungal infection? Is it a tuberculosis? Or is it a malignancy? Then you take a tissue biopsy as well at the same time and do a brushing. That will definitely give you an answer what you are dealing with. And based on what we see, gene expert does come positive on bronchoscopies as we have seen here as well. And normally you would expect, if you've taken a good biopsy or brushing, you would expect the tissue diagnosis as well. And that's what happened here.
One small question. Do we have tracheal stents on the way in future or no?
Of course, the tracheal stents are already here. They are already here. But the problem is we are talking about the complications. I am actually a very, very basic doctor. I start from basics. We need to prevent the complication. We should not, for me it's very easy. Endobronchial TB, I will get a lot of procedures. That's what I'm looking for. The patient is going to suffer forever. So if it's endobronchial TB, if I diagnose it early, if I prevent the stenosis, there are a lot of complications. It does not require further stenting, it does not require further surgery. He will thank me forever. If you miss endobronchial TB, your patient, even if you are given a TB treatment, your patient will curse you forever. So please think about a patient as your family member. What would you have wanted? Do you really need a bronchoscopy? If there are clinical findings, obviously we all will miss a lot of things. So I'm not saying we are perfect, but there has been scenario. If you clinically find your patient is not improving, there is something missing. I did not show because the CT was running too fast. There are slit signs. You can actually see the narrowing happening there. You can pick it up on the CT scan. You should send to a pulmonologist because of this competitive doctor and medicine issues. People don't refer. We are not going to keep anybody's patient. We do send them back. But we give you a diagnosis which you will thank forever and your patient will thank you forever.
Questions, please?
Yeah. So this is for everyone who's having their dinner also right now. Dr. Raj Kumar.
Dinner.
We all are, all of us sitting here see pneumonia on a day-to-day basis.
Including us.
PAL done timely versus after 96 hours of IV antibiotics. Again, there is a study done, and there was a large study published from Ames and Tata Hospital where they said within 48 hours of lung infiltrates on X-ray, the mortality reduction was to the tune of 25 to 30%. What would you advise for a community-acquired pneumonia? I'm not talking of oncology, but for a community-acquired pneumonia, what is the role of PAL? And second thing is lot of talk about biofire. Gangaram Hospital started the first panel of biofire and they said 8 घंटे में हम treatment report देते हैं. What is your take on biofire in terms of pneumonia?
So look, we all need to understand the indication of bronchoscopy. Keep it very, very simple. The bronchoscopy is indicated if there is a non-resolving pneumonia. Not every pneumonia needs a bronchoscopy. Now, you put things into clinical context as well. If somebody is quite unwell in ICU, getting inotropes, you have given some antibiotics and not getting better, then obviously you want to go in and find out what's happening. But not everyone who comes in the community acquired pneumonia, if the patient is stable, can even be treated with oral antibiotics. You actually do not need hospitalization. We find a lot of, because there is a conflict of interest for a lot of people, not for doctors, for corporates, so people get admitted, but there are indications when the patient can be treated as an oral antibiotic. There are situations when the patient needs.
Dr. Tulsi ke baad. Dr. Tulsi has a question. Thank you, Dr. Chavan. Dr. Vora dwelled on pneumonia. We could dwell on so many other things in pulmonary diseases. But let's dwell a little about what two cases he presented. Namely, the first case was on...
Sir, you spoke of 5 years of Savor and Tabor. In a young patient, 5 years does not make any difference. But that also from circulation.
But this wasn't circulation, it was prestigious journal. Well taken, Dr. Amit. Very well taken. Let me ask about those two cases to Dr. Raj Kumar. Sir, regarding your first case, you said corticosteroids, but corticosteroids, stenosis is highly debated. It's probably the photodynamic therapy and the surgical intervention will probably take care to address the severe stenosis here. Corticosteroids are still debated in here for severe stenosis.
Alright, so let me answer in this way. So medicine is not black and white. Medicine is more of a gray area. And there is an inflammation going on. And that's why these patients develop stenosis. So if you use antitubercular medication and then use steroids along with that, that's my personal experience. There are data which are in favor. There are data which say it does not do anything at all. But we do not find a significant data which says if you are on antitubercular medication, you are given steroids, the patient will be cured.
Let's dwell on the second case. So that was autoimmune. Was it Wegener's?
Steroids under the cover of antituberculars are allowed.
Initially yes, but once the stenosis is occurred, they no longer are not effective.
That's a very long procedure actually.
That's what I said. On my your second case. So that was the autoimmune disease. What is Wegener's? So if it was Wegener's, it is an anti-GBM disease.
Alright, so I think you missed the panel which I did show. So there is a vasculitis panel we did for a GBM testing as well. So what I am trying to show is, the idea is not to discuss Wegener's or polyangiitis. The idea is to show somebody who is quite unwell with a hypoxemic respiratory failure, even with a hemoptysis, the patient can be put on ECMO and we should not worry about anything. So I think we are just graduating, that's not my...
So when we are dwelling on ECMO, Dr. Juneja and Dr. Dhall, the recent ACC 2025 conference in Chicago, were you there? No. So they said in AMI-CS, anterior acute myocardial infarction, cardiogenic shock, ECMO and IAB-E has now a class 3 recommendations as compared to the coaxial pump, which has a class 1 recommendation today. So there is a legal concern. Do you have this coaxial pump in your hospital?
We have not yet implanted an impeller device here.
Yeah.
Yes, but it is an option, and at my earlier center, there are high risk angioplasties, and the patients who could afford it were offered a coaxial pump, and that is an indication. I also showed in one of my slides that it is for this cardiogenic shock subgroup of high risk patients.
Sweeping changes in the recently concluded ACC. Thank you, sir.
I think, friends, we had wonderful discussion, and all of you would agree that all the three speakers did a wonderful job. And I am sure they will remember this CME for some time to come.
some ethical questions, some scientific questions clouded in ethics, and I would request them to please accept acknowledgement from all of us. Give them a big hand. I would request my moderators and my speakers to please come here with the marketing team of Indian Spinal Injuries, some senior spokespersons.